Now the anxiety has been created in everybody's mind. The day of biovascular scaffold is over. I just would like to remind you about what we used to face in the early days of stenting. This is in the early 90s. The stent thrombosis was something which all of us were very, very worried when we started using the stents. Those were the days we used stents only for the patients who had to be bridged against surgery, not as an elective procedure. This is from our data, which we presented in the mid-90s. We used only aspirin and heparin, and then bridged over to oral anticoagulants. We had, you can see, subacute occlusion with warfarin was 20%, major bleeding and vascular complication was 27%, and death was close to 4%. Then we stopped using this device. Subsequently, we learned about how to use it better, of proper stenting technique, as well as use of other dual antiplatelet therapy. Then the result changed. Total revolution happened. That is what we are practicing today. Look at the data from Mary Claude Morris's, the first trial, the REVEL data. We started seeing a figure of zeros, even at the end of 1 year. The results were very, very promising. That was the party time for all of us. We said, time is up, the surgeon has to go out. We will put stent everywhere. That suddenly changed. We realized there is problem with the stents, right from the basket late as well as all the presentations showed what is the problem we face. The target vessel failure with the taxus as well as cipher was phenomenal. The signs, the next generation stent, the science proved that it is, we can change the setback to a better outcome. Why did we need BRS if the plain metal stents are as good as what we imagined it to be? We wanted to avoid a permanent implant, expect to solve late problems related to permanent implant, and expected the BRS to completely vanish from the vessel wall. To achieve late lumen gain, open up jail side branches, disappearance of protruding stents, and no malapposition. This, again, all this imagination came from the initial cohort of the BRS data. We started seeing the 0, again and got very excited. That's what happened. And the Absorb China also contributed to that. The TLR rate was very low. The very late and late stent thrombosis was 0. Again, excited us further. Absorb Japan data showed some change in alteration of this data. The definite and probable stent thrombosis was shown to close to 4%. We started sitting back and thinking. Absorb 2 data again reconfirmed our doubt. There was significant amount of patients getting into problems with the Absorb 2 and the BRS. The 2-year composite endpoint, again, TVF was 8.7%. And MACE was significantly higher. The clinical outcome, again, proved the same thing. The secondary endpoints also was, again, in the same line. Clinically indicated TLR was very high, as well as the very late stent thrombosis was significantly higher than and the science which is already available and well into the market. Absorb 3 reconfirmed and put us all to hold back and think there is something which is not right. This reconfirmed all these doubts we had about the TLR as well as the stent thrombosis. The clinical endpoint at 2 years put us all on guard. But if you look at this slide, you look at all those single-center registries, something different we are seeing. We see 0, 0, 0 in those data. They are not small numbers. This made us go back and think whether something wrong or something right somebody is doing. If you go back and look at those data, we understood there was a difference in implantation technique as well as different selection of patients. A review of all these single center data and centers which were using the imaging as a standard practice for all BVS found out that malopposition was one of the major concern, which was predictor of stent thrombosis, incomplete lesion coverage, as well as underdeployment and multiple stenting or multiple layer of stents. These were the things which predicted a higher restenosis rate. What are the shortcomings, what we learned from these devices? The thick struts, poor deliverability, limited overexpansion capability, as well as poor fluoroscopic visibility, which tend to produce a double-layer stents. What are the unanswered questions? Ideal material we have not found. Design has to change. Optimal implantation technique has to come in. How to overcome these issues? Optimal risk factor management, prolonged dual antiplatelet therapy, and appropriate patient and lesion selection, as well as improvement in the implantation technique and newer BRS. All this information we got from the analysis of the data of all these trials. We understood that implanting this device in a vessel less than 2.25 is very risky. What are the newer generation stents which are available with the thinner strands and other materials? There are several trials ongoing, and we see some encouraging results. And this is one of the stents available from India. The trial is still ongoing, and we found that this has got a much bigger strut thickness, broader struts and thinner struts with only 100 microns, and the results have been extremely encouraging. The optimal implantation techniques, now we realize the preparation of the lesion, size appropriately, and post-dilate is the goal to go. All the data, when we analyze from these, where these steps were taken, have been extremely encouraging. What is the way forward? To need to implement the current understanding of the original trials. We need to perform all future BRS implantations in the trial registry setting under the PSP guideline. And what is the way forward? BRS is a new and promising technology, has a similar one-year outcome as best as the second generation DES. Late failure continues to be a problem. Optimal implantation, prolonged DAPT may reduce these events. And second generation of BRS are expected to address most of these problems. And I firmly believe BRS are here to stay and will be the standard of care in future. Thank you very much.